Imagine you are in the operating theatre and you have been asked to place some sutures. These are going to be the common sutures you will be asked to do in the OR when you're a medical student or a junior surgeon looking to get some exposure in the OR. It starts with instrument handling. Needle holder, forceps, fingers in the rings, middle finger on this joint here, index finger to stabilize. Forceps go above your index finger, not under. This is how you do your brows and your stray facial hairs. This is how you have precision and control. You mount the needle 2/3 along the body. This is the point, this is the body, and this is the swage where the suture thread attaches. You mount it 2/3 along the body. The scrub nurse will usually give you the instruments, and the first suture you're going to be asked is to do the interrupted suture. We'll do this with a wide view and then we'll zoom in for that really focused view. So you don't need to pinch the skin, just go in at 90 degrees. So this is how you're holding the needle holder. You go in at 90 degrees and you pass it through. The interrupted suture is the most common suture you will be asked to do in the operating room, so make sure you can do it well. You lay the needle holder in between the long and the short, and you wrap twice. That's the surgeon's knot. You then lay the needle holder between the long and the short, you wrap once, that's a reef knot. The long and the short have to alternate in their position, otherwise it's not secure knots. If the long and the short go back to the same place, that's a slip knot. That is not a secure knot. A secure knot has the long and the short alternating on both sides. So you're going to go up and then you're going to come down. If you put the two threads together, it means you want somebody to cut both. If you put one down and one up, it's the one up that you want to cut. I would do this if I'm doing interrupted. I would do this if I'm doing continuous. The person will cut, your assistant will cut here if it's a scrub nurse that's got the scissor, or the surgeon that's asked you to do the suturing. Because I've only cut one suture, I'm going to now do a continuous suture. That's an over and over and over suture. You do that for long linear wounds. Again, it's an essential suture for your time in the operating room. Here I'm using a dissolvable suture, and we're gonna go over and over like this. Maybe slightly bigger bite there. So go in and mount it straight away and pull through. Take equal bite from both sides, mount it straight away. And when I say mount it straight away, what I mean is you put it through with the forceps, mount it right now and pull. What you don't want to do is this. Put it through with the needle holder and then have to grab it, mount it, and go again. This is inefficient. You want to do it like this, and it just saves you so much time because you're so precise. And it's these things that somebody supervising you in a theater will be looking at to see if you're ready for the next step. When you get to the end of your continuous suture, you leave a loop. Treat it like a single knot. 1, 2, grab the very tip of the loop and pull it down. Treat that loop like a single knot. In the same way, your suture ends have to alternate, so going up and going down. I've got a very short thread here, but we move. This is one of the ways plastic surgery do it. We're very economical with our sutures. So we're covering all the tips and tricks for when you're assisting in the OR. The first suture you will ever be asked to do is the interrupted suture. And we're just talking about, the hidden language of suturing. So the first tip we really talked about, talked about interrupted suture. You can learn that from our page. It's what it means when somebody holds up the different ends of suture. So when somebody holds up the suture ends like this, you cut both. If they hold up just one, you cut the one that's up in the air. In terms of when you're cutting, how you hold your scissors. Many times when somebody's first going into the OR, they go in like this and they start cutting like that. That doesn't show experience. You open the scissor, you go onto the suture, you slide down to where you want to cut to, and then you cut. The other situation you can find yourself in, if your dominant hand is holding, say, an artery clip, and the surgeon is tying maybe a blood vessel, you may only have your non-dominant hand available to cut the suture. In that instance, you have to use your non-dominant hand to do that. So the way I do that is index finger and thumb are holding one ring, middle and ring are supporting the other, and you're just going to open and close. And so as you can see, I'm going to cut this suture. You have to be a bit more controlled. Don't open it too wide. Open and cut. Open and cut. So left-handed and right-handed suturing. Obviously, if you're doing it with your right, mount your fingers, ring and middle finger, ring and thumb, sorry, middle finger on the joint, and you cut. So we've covered the interrupted suture, the continuous suture, holding either end of suture. What it means if the person holds two sutures up, that means you cut both thread. If you hold just one suture up, another one's down, you cut the suture that's up. The next suture that you're commonly going to be asked to do in theatre when you're assisting as a medical student is the deep dermal. The deep dermal buries the knot. You go from deep to superficial. Mount it early, and then you go from superficial. So if you notice how I've changed my position, I went from deep to superficial and was mounted. Let me pop this down. I went from deep to superficial with my fingers mounted, and then I palmed it to go from superficial to deep. So my fingers are outside of the needle holder. I reflect the skin back, and I go from superficial to deep. And I make sure I'm deep in the substance of the skin, in the dermis. You don't want to stitch fat, you just want to stitch in the dermis. You lay your needle holder between the long and the short. One, let's do it properly. 1, 2, grab the short and you tie it parallel to the skin. Look at that. If you tie it perpendicular, you just open the wound. So it has to be parallel. And then your knot remains buried. Again, if you hold both sutures up, you cut both. If you hold just one up, you cut the one that's up. I'm going to hold both up, telling the person that's going to cut my sutures to cut both. You open, you slide down, you angle it, and you cut. Let's do that again. See if we can zoom in this time. So we go from deep to superficial. I go obliquely to get good purchase. And then my fingers come out of the needle holder. I hold it in the palmed grip. And then you go from superficial to deep. If you like what you see, like the video. If you have any questions, drop some comments. We're just on a mission to give people everywhere, medical students, aspiring surgeons, nurse practitioners, the skills they need to close wounds in any circumstance. So we have covered the interrupted suture, the continuous suture, the deep dermal. I would say the last suture which you need to know about if you are in the OR is the subcuticular suture. Once we've done that, as we do the technique for the subcuticular, I'm going to talk to you about suture selection. So, and then we'll just cover some of the things we've already covered. So mount it straight away where you want it. Fingers are in the needle holder. To start a subcuticular or intradermal suture, it's the same thing. You go from deep to superficial. You need to bury your knot, mount it, pull the suture through straight away, mount it straight away, and pull. With your left one hand, pull the suture. We're not going to be doing this and this and this and this and this. That takes too long. Just pull the suture with one hand. Put your needle where you can see it. Don't let it come out of your surgical field. I'm just going to tie the knot. 1, 2. You see how I just push the suture through and it forms the loop? 1, 2. I'm not doing this. I'm just pushing it forward. 1, 2 around the tip of the short end, and tie, and the knot stays buried. Some people would do the opposite side as well. I don't think it's necessary. Again, if you hold both sutures up, you cut both. If they hold just one up, you cut the one. Because this is a continuous intradermal suture, this time I'm holding up. The short end that we cut flush. This is down so you can see what I'm doing. And then we're going to run that suture transversely. So I'm going to do the far side. The key to getting this is actually really, I think, suturing the apex. The apex is where you tend to have gaps. Take small bites, mount it straight away, and pull. Pull it in the direction of the wound rather than up in the air so you don't pull anything out. You go in opposite where you came out. So I'm going to go in here. If you like what you're seeing, you're learning, feel free to like this stream. Push it through. Grab it with the forceps. Mount it straight away. Not quite right. Sort of adjusted. Pull the suture. See how nicely that closes? You go in opposite where you came out. Make sure you've got good excursion and bite and purchase in this tissue. What I do is I take my fingers out. If you watch my fingers, I've now extended my wrist, reflect the skin back, and I go all the way around from here, and then I flex my wrist and come forward. So my bite goes all the way up and all the way down. I grab it with the forceps straight away. Well, I try to. Not the point, but the body. Mount it straight away right here and pull. We're going to get to the Aberdeen knot at the end of this, or the French knot. It's a buried knot. And then on this side, I go through. Suture selection is important when you're doing your suturing. To classify sutures, to group them, you have dissolvable and non-dissolvable. You have monofilament and you have braided. If you have a non-dissolvable suture, the sutures need to come out at some stage. Typically, sutures come out in 2 weeks. In most places, in the face, they can come out in no more than 7 days, sometimes 5 days if it's like eyelid and thin tissue. Over joints, I tend to leave the sutures 3 weeks, 2 weeks for half, and then so at 2 weeks I take out alternate sutures, and then at 3 weeks I take out the remainder. Because over the joint, the wound will open and close, so it's under tension, so it will take longer than normal to heal. So we're just doing the intradermal suture. We mount it straight away so it doesn't take too long. We're using a monofilament dissolvable suture in the form of PDS. It's violet. That means it's dyed. If I was closing skin in a real patient, I wouldn't use a dyed suture because there's a risk of it being visible and a bit of tattooing of the skin layer. You use the undyed. You want to get good purchase as you go around. I need to do at least one more bite, mount it straight away on my side. Just pulling with one suture along the axis. And then I need to anchor this at the end. Because we're going to do the Aberdeen knot, the French knot, or just the buried knot. So you have a loop and you have your needle on one side, the loop is on the other. So to do this, I'm actually going to do it this way. So the needle's on the long suture and the loop is here. Index finger and thumb keep the loop open. The needle does not pass through the loop until I've tied all the knots. So my index finger scoops this long suture, and there's two sutures here of the one loop of the long suture on this side. I'm pulling the inferior, the under loop. I'm watching the knot slide down. Because I haven't pulled the suture through the loop, I can reform the loop on this side. Again, pull, 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 pull. If you're using monofilament, you need to do between 4 and 6 knots. If you're using braided, you can do 3 to 4. Now I've done all that, I'm going to bring the needle through the loop. Make sure the knot goes nicely flush down. If you're getting value out of this, please feel free to like. If you have any questions, pop them in the chat. We do members only lives once a month. Do subscribe if you like what you see. We have these videos to watch on repeat in the live section of the MedSync VT page. So to bury that knot, you take a bite inside and it closes the wound without any sutures material on top. If I go like this, it means I have to cut it. Because it's a dissolvable suture and it's subcuticular, you cut flush with the skin. So flush with the skin means on the skin, not the skin there, and cut. And then, you know this trick, we do it all the time. Turning it down for economy of movement. So if you have to cut again. The last suture you tend to be asked to do is the horizontal mattress. So you go across, you turn the needle around, pull the suture, you go in adjacent to where you came out, you come out adjacent to where you've gone in. This is the horizontal mattress, and this is, I'd say, is the final of the most common sutures you would be asked to do in an operating theatre. And watch how it everts the skin edge really nicely. Just puckers it up a little bit and make sure that you get dermis to dermis and epidermis to epidermis. If you notice when I tie my knots, it's not this big movement, it's just in the wrist, a little curve around the tip. Let's do that again. So if you notice, when I do my horizontal mattress, I mount the reverse quite quickly. So I push it through, I grab it straight away with the forceps, and I do that for any suture that I'm going to continue suturing. What I showed you before was that I turned my wrist around, the curve is up, the point is here, I mount it how I want it, I then take my fingers out of the needle holder, and I pull the suture. I'm going to do the horizontal mattress. I go in adjacent or next to where I came out, and I come out adjacent to where I've gone in. Now you might wonder how I'm unlocking the needle holder when I'm in reverse. If I'm mounted like this, and I go like that, unlock the ratchet, my theta eminence just pushes this up. So my fingers keep this ring down, my theta eminence pushes this up like so. So it's that down pressure on this one, up on this one. Look again, up and down. You can do the same with your non-dominant hand. These fingers push that up, these fingers keep that down. One more time, and one more time. So you have to be a bit ambidextrous when you are a surgeon. Keep the loop there, keep the needle there. 1, 2. Horizontal mattress just everts your skin edges a lot more nicely than interrupted, so that you get dermis to dermis and epidermis to epidermis. So the other way to turn the needle around is push it through, put it through, grab it straight away, pull the suture, and then you just carry on suturing. It's just a bit more economical. I wouldn't say it's any longer than the other technique, but it just works. 1, 2. Look at that eversion. And again, it's just you push the suture forward, wrap around the tip, wrap around the tip. And put both sutures up if you want to cut both. Put one suture up if you want to cut one. If you want to cut both, I pass all the instruments into my one hand. My scissor just comes out like this. And I cut. And that is our session on the common sutures you need in theatre when you're assisting as a junior aspiring surgeon or as a medical student in the OR. We covered the interrupted, the continuous suture, the deep dermal, the subcuticular or intradermal, and the horizontal mattress. Anything after that, I would say, is a more advanced suture. I think these are the common ones you should definitely practice. So watch this video again and refer back to it if you ever need. Subscribe if you loved it. Like the feed if you want more. Drop any comments and any suggestions on any videos you would like us to go take you through next, any skills you'd like us to take you through next. On that note, have a good evening.